be used in hypertension, because hypertension itself is not can be categorized as a one condition that we have specific treatment. It depends on the condition. After that, we discuss about these classes, because previously we teach antihypertension as a classic pharmacology. How many classes we have with the first line, and then what the second line. Then we talk about the classes, what the members of each class, what the mechanism of action, adverse effect. And we give the brand one drugs we take. Broad drugs that can have, how to say, the general important pharmacokinetics. So this is the classic teaching antihypertension. But nowadays, hypertension, even though describing antihypertension drugs, you have to consider many things. So I start from applied point to this, to that. We inflict the teaching so that you can, I hope that you can get your interest. I know it will be heavy, not that light. So I need your attention. So if you have any question, you can ask me after we finish. And I don't think so we can able, but I try to stress on the most important point so that you can, later on follow up or build your notes or build your knowledge about this topic. Okay. As usual, any session, we need to know what the learning outcome. So maybe someone asks, why we make it in easy way? Because if easy way, you can get any textbook pharmacology, no point. Rather than to stress the important point that you can develop your knowledge on that. So we need to know the classes of antihypertension. So that how many classes, so that almost, I think, if not more than 10 classes of this drug, antihypertensive drug, or more than 10 classes that can be used in treatment of hypertension. Then we need to know about the mechanism of action. I try to classify or name the classes based on the mechanism of action, so that's easy to us to remember. Then we need to see about the role of angiotensin, beta-glucocorticosteroid, and diuretics role in optimized antihypertension. So that means optimization treatment, one of the challenging type of patient, one of the challenging, and comorbidity also another challenge. So we need, and also another challenge, so many classes for this disease you have to select and prescribe for your patient. Okay, as usual, I put for you in the first slide a few definitions so that it can help you when you read the slide later on. And then very important for you to understand the term, because sometimes we ask some question and then this is the key for the questions. I will not explain much, but you know the term or you understand what does it mean, so that easy for you to understand the answer for this question. So I have no need to spend time. I put for you the last statement here is one of the institute that are responsible for preparation the guideline for treatment of many disease, one of that hypertension. One is very interested for an institute that can help you in practice later on. You will be given on the guideline. So I will not take time, so I will try. I think no such how to say only the point as a term. At the same time, you have to know what different type of meditation, how the classification, the different term or meaning for these classes, for these terms. Okay. As I mentioned before, management or treatment of hypertension can be two main parts, non-pharmacological and pharmacological. When I say non-pharmacological, that means you give advice, lifestyle change, this is what, but it's not enough time to discuss, to explain, and this one can get it later on in your experience. And more our emphasis will be about pharmacological, that the drug that can be used in the treatment of hypertension. Okay, and the second point, you have to remember, once patient get hypertension, cannot cure. So that they have to take this medication for long life. You have to remember this one. So that when you decide to give your patient, and you have to monitor their blood pressure very well. Okay, what else? The important point. Look for the last sentence. Blood pressure treatment is very important. Very, very important. Why? Because untreated or suboptimally controlled hypertension led to increased cardiovascular, cerebrovascular, and renal morbidity. You can imagine. If not blood pressure controlled very well, maybe kidney problem, organ damage, one of the main important, how to say, organs is the kidney. Okay, so we need to control or monitor the blood pressure very well. So you have to advise your patient, and you have to make sure you prescribe the suitable drugs for your patient. So this is the challenging aspect. So why I start in other rather than to discuss about how to say the classic antihypertension class. So this is I give just information for you. What does it mean of non-pharmaceutical management? Okay, that you manage the body weight, also consumption, smoking, healthy eating food, also relaxation therapy, dietary with the potassium intake, all these that can help in term. You can see what does it mean I say body weight. We see the obese patient most be under risk to develop hypertension. So that you need to manage your body weight to be near to the ideal. Sodium intake, we know sodium is associated with hypertension. So that even though there is a drug that can use to reduce the reabsorption of sodium, so that can maintain the blood pressure. Healthy food, also this is a sequencing of eating non-healthy food for long term. Okay, smoking, smoking one of the main risk factor also. Stress, and even though hypertension, there is many theories that can, how to say, discuss or mention that hypertension is centrally controlled rather than peripheral. So even though now we're taking drugs that can control the heart and blood vessels to maintain the blood pressure, but still the main causative, you see there is many theories. Okay. For management of hypertension, we have several points we need to focus on it. The type of hypertension, that means there is several classification for the hypertension itself, so that can control or can give you some idea what the main drugs can be used in this condition. Type of patient, when I mean type of patient, maybe can be, how to say, patient with hypertension only, or patient with other comorbidity like diabetes, how to say, dyslipidemia, and this is most common of polypharmacy drugs or multi drugs used in all patients. All this one they give you some also point that you need to take care with specific drugs. Age also, geriatric, I cannot, also they have some restriction when I compare to young adult hypertensive patient. Gender, and male or female, the main important is pregnancy, and nowadays we have complication and preeclampsia, and this is quite common nowadays. We can see that hypertension with other symptoms that concurrently with the pregnancy that can make the patient or women under risk during the pregnancy, and they have specific treatment for that and the rest. So all these factors we need to consider it. But don't worry, just I need from you to know, now we are not in the practice, just we need to know the fundamental behind that so that you can identify why we have to choose this medication, why it's contraindicated, even though for antihypertensive drugs, and why they prefer, so that is very important. Okay. Now, management of hypertension based on pathophysiology, what they already teach in the pathophysiology, there is some problem in glucose resistance, so that can create hypertension, right? So that we need some drug that can reduce the peripheral resistance, that can minimize the blood pressure. Okay. Then how to say this one of the factors that can affect the blood pressure or heart rate, that increase the blood the peripheral, so maybe it can be more than the requirement, so maybe can take to increase the blood pressure, or how to say the volume, systemic volume, so that volume or the amount of the blood may also lead to how to say lead to the hypertension. So general rule for antihypertension, that we need to normalize the peripheral resistance and blood volume and or viscosity of the blood, so that can minimize the blood pressure to the control, to the normal level. Okay, what's this? How to say now? If I want to decrease the heart rate, so I need to. We know this. We have beta receptor, beta 1 receptor in the heart, so that if I block this beta 1 receptor, I can reduce the heart rate, and that can reduce the blood in the circulation, so that may can involve in the reducing the hypertension. Okay, for the blood volume, diuretics. We have a class of the blood we call diuretics that involve in how to say reduce the how to say ions like sodium and chloride, and with this reduce reabsorption will how to say affect on reabsorption of water to the body, so that we osmotic pressure or directly the excretion within the urine, so that can decrease the volume or the fluid in the blood, so it may also involve in decreased hypertension.
Boom.
What?
Boom.
If there is an emergency condition, hypertension crisis. Good. This, we need this time, we say in the middle when we already have fine. Okay, the second class, another classes that can reduce the peripheral on the right side of the ground. We can see how to say decrease the vascular tone, so that can minimize the constriction of the blood vessels, so that can dilate, so that may involve in decrease the blood pressure. But we cannot say normalize the blood pressure. It may lead to involve in decrease the blood pressure. Or we have so many classes here. You can see involved in the calcium channel. If the calcium channel block, so that can lead to vasodilatation and have decrease of blood pressure. And we have one class we call calcium channel blockers. Activation of the potassium channel. If we increase the open of the potassium channel to outside, also we are not allowed to enter another electrolyte, so that also make the vasodilatation. Alpha receptor. Alpha receptor, we know from autonomic nervous system, is can cause vasoconstriction, right? Vasoconstriction, then we have alpha blocker drugs, especially alpha 1. But alpha 2 is have a negative feedback, it's opposite way. If you block the alpha 2, that means you will increase the norepinephrine release, so that can increase the signal of sympathetic, may lead to increase the hypertension. So here alpha 1 is alpha 1 blocker. For how to say endothelial and angiotensin antagonist, this is a new groups coming in the market. We have angiotensin uh, receptor also. So we have within angiotensin receptor also we have before that angiotensin converting enzyme inhibitors so that they can inhibit the production of angiotensin 2, which they activate the A2 receptor or angiotensin 2 receptor. So that all this they cause vasoconstriction by different mechanisms, either direct stimulation the receptor or stimulate secretion of aldosterone. Increase aldosterone will increase the reabsorption of sodium and also water and lead to increase the hypertension. Okay. Also, before that, we have also the renin inhibitors. Renin also is released from the renal. Is stimulated by the normal based on the potassium and blood level, so that can stimulate the renin release to make vasoconstriction and complication lead to increase the blood pressure. Also, renin is one target, and we have one class that can inhibit the renin. Once they inhibit the renin, so that will inhibit conversion angiotensin 1 to angiotensin 2, because angiotensin 1 is not hypertensive agent, so that it should be to be active to convert to angiotensin 2, so that this conversion based on renin. Okay, we have one class. So all these, you will see all these classes only involved in the vascular tone. So one vascular tone inhibit, they will make dilate, so that can minimize the hypertension to some extent. Clear? Okay. Now we come to the main one of our objective for our learning outcome topic today. We have the classes. You can see how many classes. 1, 2. I put 2 many class based on the pathophysiology. I try to link with the pathology easy for you to remember, so that the drug that can involve in the blood volume or how to say cardiac output. We have 2 classes: diuretic and beta blockers. Okay, we have 2. In other classes, as I mentioned before, we discussed about the diagram before in the slide before. We have so many classes. We, according to the Malaysian guideline, I try to do the classification so for easy for you to go and link in the practice, rather than I use the US or NICE guideline, so that we can link with the fundamental. So we have here around 4 classes, like according to this Malaysian guideline. We have calcium channel blockers, renin-angiotensin system blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, renin receptor blockers, and macedonians. Macedonians, we have alpha blockers and combined alpha and beta blockers. Centrally acting agent, central antihypertensive agent, direct vasodilators, and drug in the development. At least you have some knowledge about it later on when you graduate. When you go to the practice, you have some idea that there is drug under investigation already. Some of them in clinical trials. Okay, how about traditional herbal medicine and hypertension? Because here in South of Asia or Middle East, we like to utilize herbs, and definitely you will face some patient come to you using herbs. So how to say in the management, what the role of this traditional practice? Is it acceptable? What do you think about it? So this what for you one slide for your knowledge. Okay. So I think this is quite big. So I need your attention, so that if you have anything is confused, don't hesitate, you can list it, then we can have a discussion whenever you have time. Okay. this is now we discuss just we give the beginning, then we give the overhaul about the drugs using in treatment of hypertension. Okay, so that we and then what the other factors that involve in prescription this or giving this medication for your patient. Now, how about hypertension itself? As I said that because hypertension is not only one disease and one condition, right? So that normally hypertension is easy to measure without any invasive technique. It's a normal, it's a simple technique to able to take the hypertension. And look for this point. I need your attention very well. Definition for control hypertension according to the current management guideline. Okay, so that we need to achieve blood pressure for systolic and diastolic 140 over 90 for all patients. Below this level, okay, general for the hypertensive patient. Remember, but if your patient with diabetes, diastolic should be less by 80. And we have to think why with the diabetic patient you have to achieve the diastolic up to 80 millimeter mercury. Why? Think about it. It's very important. This is the according to the guideline. If your patient, hypertensive patient with heart problem, like ischemic heart disease, cerebrovascular disease, or renal problem, you have to achieve both systolic and diastolic to less than 130 over 80. Less than this value. So now another factor is coming in, right? So now which drug can able to minimize up to this level? So I think at least around 10%, I think is no problem. But when I go to reduce in the diastolic more than 10%, it's not that easy maybe. So now there is monotherapy and combined therapy for treatment of hypertension. Later on we'll see. Okay, clear? Guys, the last. Okay. Now, type of therapy and blood pressure. And I say that so that there is two types, either monotherapy or combined therapy. So when I have to think about monotherapy, that I mean that I can prescribe one drug, right? Combination that more than one drug. Okay. In monotherapy, most of the guidelines they say if your patient at the stage 1 of hypertension, sometimes classification they say stage 1, stage 2, stage 3, some other classification they say mild, moderate, severe. Okay? And there is a category I put to read the slide. So if your patient with the stage 1 hypertension, so without any other comorbidity or any other risk factor, so I can start with the what? Monotherapy. So that you see here, monotherapy, choose monotherapy in the patient with the stage 1 hypertension with no complication. So maybe you can see some question in MCQs or maybe a scenario. So you have to understand this one easy for you to, retain the proper action for the scenario, the case coming of the MCQs that you can able to understand. From you here, we need to understand the concept. So the question, each question later on the practice, in the exam, on the practice, you have to develop on the concept. What the concept? So you have to identify which the key point, not just direct to answer blindly or just when you think either it's okay or not. You have to pick on the concept. Why? When you pick on the concept, if the question answering is not proper, so you can learn. Later on you will improve. If you are okay, so then you can start carry on, improve on yourself more and continue with the right proper way you start. Okay, combined therapy To choose combined therapy in the patient with a medium, high, very high risk in the stage 1. So once, not only the stage 2, if the patient is stage 1, but and the risk either comorbidity, have another disease, or have any other risk factor, so that then you can go with that. Blood pressure or systolic blood pressure should be, as I mentioned before, should be less than 140 and less than 90 millimeter mercury, so that you have to achieve that. If the patient with a high risk, so it should be less than 130 systole. Okay, and less than 80 in the estimate. And this is the categorization for the blood pressure. If I want to say normal or optimal, this optimal should be less than 120, 120 or less, and less than 80 the diastolic. For normal can be average, so there are several factors, the device, the position, the time, so that they get that from 120 to 129 systolic, and from 80 to 84 is the for diastolic, so that this is the average for normal blood pressure. If the patient at risk, so that should be maintained the systolic from 130 to 139, and or from 85 to 89. Okay, and this is the figures in the last column is about the prevalence in our Malaysian population. So this all is very important. Okay. So that classification, when I say hypertension, stage 1, 2, 3, or isolated systolic hypertension, this is the classification and this is the characterization. Try to remember. So I advise you to print this, or you make a tables, make it in the front of your mirror every morning when you check yourself. Just remember the numbers. So just you can easy to remember very fast. That can help you later on in identify what stage we should prefer to give this medication. Will help you more. Okay. Now, so I start with. I think diabetic nowadays is quite common, right? And it's affect our lives. So many. I think population with diabetic nowadays. Even though younger, I can see diabetes mellitus type 2. Okay, less than 30-year old. Last time we see this after 40 years, 50 years, we can see diabetic nowadays even though less than 30. So now, if you have hypertension in the patient with the diabetes mellitus, so what they recommend, so that based on this recommendation, we discuss about it. Normally, for this one, you have to, if this achieve, should be the blood pressure less than 140 over 80, less. So to achieve this value of the blood pressure, they prefer to use angiotensin converting enzyme inhibitor, ACEIs, angiotensin converting enzyme inhibitors, okay, in the diabetes, because they have so many advantages. Later on, under these classes will have some slide explain why they prefer. Okay, also angiotensin receptor blocking. Also, they can be used when normally they will start with the angiotensin converting enzyme inhibitor. If not, you can say is available, and also the cost is suitable, not that expensive. But sometimes they have one adverse effect. Your patient cannot tolerate this medication. Okay, but keep in your mind when it comes to this class, we'll discuss about it. So just now, we need to know which to prefer the classes of the drug. If I have patient with a hypertensive patient with diabetes mellitus, which classes is preferred? This is the most important here. Okay, so now all two classes, ACE inhibitors and ARB class can be used. So another classes, calcium channel blockers, diuretics and beta blockers. Also they how to say, recommend according to the guideline treatment of hypertension, but with some, you know, take care of taking this medication. Only this one can be used if renin-angiotensin system, say RAS, renin-angiotensin system drugs cannot be used, like for ACE inhibitors or ARABs or renin inhibitors. So I will go for the second, calcium channel blockers or beta blockers or antidiuretics. Okay. As I mentioned before, I need to achieve blood pressure less than 140 over 80. It is considered to lower to 130 less than 80 in young patient, in younger patient. And this is if the quite old adult, I can go for 140 over 80. But if still your patient is young adult, you have to consider less the value 130 over age. So if the question coming, you have to think about the age. You have to think about the other disease. So you can affect your answer for the scenario, the case. Beta blocker and selective beta blocker or alpha blockers, beta blockers or peripheral alpha blockers may use with care, with care. Why? There is explanation later on. But now in this slide, I remember, okay, I can use the IC inhibitors, ARAB, as the first line in treatment of hypertension with diabetes. If these drugs is not suitable for any condition, I will go for calcium channel blockers, diuretics, or beta blockers. Okay? And then, especially beta blockers and alpha blockers can be used but with care. With care. Why? Just put question mark, then we will see why. So later on I will go in this way so that to save time, we'll see which the class of the drugs will be prepared in each condition. Later on we'll explain more in the next slide. So now hypertension with renal disease. Please be here. So if you have a patient, hypertensive patient with a renal problem, so that renin-angiotensin system blocker as initial antihypertensive therapy for patient with micro and macroalbuminemia. Forget about it. Just if you have any renal problem, also renin-angiotensin system is still a choice of drug. Okay. Also calcium channel blockers. Actually, in calcium channel blocker, we have too many classes. So don't worry. Just we call non-dehydropyridine calcium channel blockers. If the goal is still not achieved, that means we cannot reach to the blood pressure level required. So that we can go also with the calcium channel blockers. Okay. Concurrent diuretics can be considered in the therapy, and also give some non-pharmaceutical advices, also the restrictions and water restriction as well. Okay. Avoid dual look for last statement. Try avoid dual angiotensin system blockade in the patient with the chronic kidney disease. What I mean dual, that means can work in angiotensin converting enzyme at the same time work on angiotensin receptor. So if the patient have chronic kidney disease, try to avoid it. Okay, if hypertensive patient with stroke, now a problem with the cardiovascular, isn't it? Stroke. So that first you have to make sure the blood pressure less than 140 over 90. millimercury. Okay. In both normotensive and hypertensive patient for secondary prevention. Okay. Combination of AC inhibitors and diuretics is preferred for secondary prevention. If secondary, because hypertension can be also from primary or secondary, isn't it? So that is prevention. So you, as a secondary, you prefer to use IC inhibitor with diuretics. So blood pressure should be less than 130 over 80 millimercury for the secondary prevention in stroke patient. Don't lower the blood pressure. Look, this is some comment. If the systolic blood pressure less than 180 in the first 2 weeks, because maybe patient may be around more than 180, so don't try to reduce very much, very fast. Try to go slowly. Okay, especially in acute ischemic stroke patient, unless the hypertensive emergency coexist. It depends. Now this is some condition, right? Avoid lowering of blood pressure abruptly with sublingual nifedipine in acute stroke. We know this nifedipine is a rapid onset and short duration of action, so that not suddenly using this medication or try to avoid during the in acute stroke. Don't lower the systolic blood pressure less than 140 in the patient presenting within 6 hours for hemorrhage stroke. This is more explanation about the stroke condition. Okay, I'm presenting systolic blood pressure more less than 220 millimercury. Consider aggressive reduction of blood pressure in hemorrhage stroke patient presenting with systolic blood pressure more or equal to 220 millimercury with a continuous intravenous infusion of antihypertension and frequent blood pressure monitoring. This is just updated from NICE guideline. So all this comment is based on the practice and more effective management for your patient. Okay. Now in women with the eclampsia, this is the one common condition we have to consider for the fetus at the same time for the mother itself. Here, look, renin angiotensin blocking drugs is contraindicated. Please try to avoid it. Now we see this classes can be suitable with other hypertensive patients, right? With the diabetic, for example, and also with the renal problem. But now, if in the woman with the preeclampsia, so will be risk and contraindicated. Okay. They say provide calcium channels, provide calcium supplement to prevent this preeclampsia in the pregnancy. Normally, there is one they suggest in the guideline to use aspirin, and this is very important point in this one. Please, I need your attention here. Comments aspirin 100 to 150 milligram and taking at the bedtime from 12 and 16 weeks and continue until delivery. You think why would they start from week 12 or 16? Between this period, you cannot start aspirin before. There is one very clear syndrome when taking aspirin. Roy syndrome, right? They have how to sweating in the how to say terminal right hand legs. The babyhood, the mother will take aspirin in the early pregnancy times, in the 3 trimester, may can develop Roy syndrome. Okay, so the drug of choice now, when I say last class of the drug, renin angiotensin blocking drugs is contra or avoided in the preeclampsia hypertensive woman. So what the drug of choice? They say that the drug of choice in pregnancy is methadone. And this is very clear since I'm a student and I studied pharmacy in how to say 1990. That time I will be in the year for 1996. That I know this methadone is the drug of choice in the hypertensive pregnant woman. Okay, and they add another, last time even though beta blockers, but they add another classes also, another drug, labetalol as alternate for first line in treatment of hypertension with the nifedipine as well. So now we can see all here drug that work in the beta blockers or centrally acting later on. We'll see the methadone is due to false neurotransmitters in central nervous system, so that can decrease the blood pressure. Okay. And this is in the emergency. I leave for you. I will not discuss much. Okay, use oral nifedipine in 10 milligrams state dose to rapidly control the blood pressure in acute hypertension crisis. And also they can give them magnesium sulfate as a drug of choice for preventing of eclipse. This is for knowledge. Okay, now some women also they don't like to have pregnant, so they use oral contraceptive as well. So if patient come and get some hypertensive patient using contraceptive, so that we know this oral contraceptive on a common adverse effect can cause hypertension and also another cardiovascular adverse effect, but serious. So that you have advised your patient to change the alternate form of contraception, especially the hypertensive. No compromising. Okay? Now, the other type of hypertension, you have resistance hypertension, refractory hypertension, so that now we go in combination. I can be used with the, when I say the definition for resistance or refractory hypertension, that treat patient with at least 3 drugs inclusive of diuretic before diagnosis resistance hypertension. Okay, consider drug so that if you have case, you give more than drug combination therapy and still hypertension cannot reduce the blood pressure, cannot achieve, you have to consider many points. Maybe the patient not taking medication, so that is not adherence to the taking medication. If this is not taking the medication, but still the blood pressure cannot manage, so you need to add spironolactone as a fourth drug in the resistance of hypertension. Okay. Treatment of isolated office and mask hypertension, because sometimes hypertension can be fluctuating or not stable. Sometimes if we see blood pressure increase, suddenly it's normal, no problem. So that you have to start with the non-pharmacological management first. Okay? Then, but if your patient under for any risk, you cannot take the risk, because if blood pressure increase suddenly may can lead to many problems. So you have to go for preventive treatment. This is the main point. If your patient here is not under any risk for this type of hypertension, So maybe you can start with non-pharmacological. But if you're patient with the risk problem, so you have to start with the pharmacological problem. Like when I say patient with cardiovascular risk or target organ damage may lead to the kidney problem, so that you have to start with the pharmacological. And this is the main point here. Now, based on we discussed, this is the condition. So you can see first how we address the topics. Then we discuss about the hypertension with some analysis, which the most common class is the drug they prefer, which can be avoided. Okay, with the suitable way, with the value of the blood pressure you need to achieve. Now, I come to this slide here, the choosing of antihypertension drug for treatment. So we have a few points here. So I'm trying to address the most important point in this slide. So what we can see, the patient with a newly diagnosed, just diagnosed with a hypertension and uncomplicated hypertension with no, complaining indication, we have to start with the first line monotherapy. So that from this statement, we have to identify the first line monotherapy of antihypertensive drug. So you have to think about it. If just the patient is new without any complication or any disease or risk, only started diagnosed or newly diagnosed with hypertension. Which these classes, we have four classes under first line antihypertension drug. This is IC inhibitors, ARBs, calcium channel blockers, diuretics. Okay, or angiotensin receptor blocking. All this you can see now about in angiotensin, renin-angiotensin system. You have two classes: IC inhibitors and angiotensin receptor blockers, and we have calcium channel blockers and diuretic. Fine. Some guidelines they can mention about beta blocker as well. Last time I was student, beta blocker one of the first line after diuretics. But nowadays still can be some guideline they use beta blockers, but still have some controversial or not some issues about using beta blockers as a first line. Because when I say first line, that is the most safest drug to compare to the other classes. Okay, if you want to consider the beta blockers in the treatment, so we have 3 points here. Okay? With me? I see some student already starts heavy. I know it's heavy, I told you. Any like previous risk condition coming or okay, please pay attention. If you feel not sleepy, you can go wash your face and come back. Please. If you're missing any point, just tell me or raise your hand and I can repeat. Okay. So now, if we consider beta blockers, it's not wrong if you tell me, oh, we have 5 classes as a first line. Okay, because this some guideline they consider beta blocker as a 5th class in first line of therapy. But this guideline who consider beta blockers as the first line, you have to consider the 3 points here. Okay? So now, treatment with with beta blockers as controversial and recommendation as a first line monotherapy in newly diagnosed uncomplicated hypertension and no complaining of indication group of patients. Okay. Beta blocker should be considered in young patient. Okay. If I consider beta blocker as the first line, should consider that first point should be a patient as young patient, particularly that intolerance or contraindicated for the other classes, like AC inhibitors or angiotensin receptor blocking or blockers. Woman with childbearing potential. Okay, patient with evidence of increased sympathetic drive. So that may this the favorite condition that when you can consider to give beta blocker, the advantage over other classes. So either contraindication or some condition in the patient, or they have advantage that use beta blocker that can consider as the first line. Clear? Okay. Now, if the patient with the stage 1 hypertension, that when I say stage 1, what does it mean? Mild hypertension, right? That is the value that we have. So monotherapy can lower the blood pressure less than 140 over 90 mercury. About 2 to 50% of the patient with mild to moderate hypertension if after sufficient period of treatment. Sufficient, when I say sufficient period of treatment, normally 1.5 months to 6 weeks. If not, then you have to go for another one with monotherapy. But if still the blood pressure cannot control with monotherapy, so you have to go for three options. We have three options. Then you can, if monotherapy not control the blood pressure in the patient with the stage 1, so either you can increase the dose, the initial dose, or maybe substitute the classes, or you can add a second drug to the first drug. Okay, three options. Clear? Okay. Now, if some patient we can face some patient they don't want medication, then they want to continue, right? So what you will your action, you will try to, you will understand your patient concerning and you want to try to help, but is it that good for your patient or not? Right, that's the point here. So that they give two options here. Step down therapy, normally in the guideline, they don't recommend this carriage. This is from the beginning. You cannot agree with your patient that you don't want to take medication. Okay, fine, maybe you can, but so that step down therapy is carried from the beginning. The vast majority of the patient, however, the state of patient that following criteria, because sometimes some patients they insist they want to reduce, right? So you have to take care about this fourth point. So that patient blood pressure must not be higher than the stage 1. Should be the patient is mild, so that you can think, you can go with your patient to some extent if this criteria can be followed. If the patient blood pressure is not higher than stage 1, blood pressure well controlled with the first last year, okay, must agree to be follow up to 3 to 6 months, okay, must be motivated to adopt healthy life. If you want to step down the therapy in the treatment of hypertension. Okay. Now, we come to some point what we need to arise now. Antihypertension used with the care, because some drug you need to use it with the caution, right? Which condition? Okay. Diuretic in hypertensive patient with gout and dyslipidemia. Because sometimes no choice. You have to take this diuretic even though the patient getting this condition, gout and hyperlipidemia. Why? Okay. So that because they have the main point here, they can worsening the condition. So that patient with gout, the main symptom, the uric acid in the blood is high, right? So that when taking diuretic, will increase the uric acid. So that worsen the condition. Okay. So that you have to take care with this patient, monitor the gout or the uric acid. You think why this diuretic can interfere uric acid secretion? Think about it. Then we can take the answer the last. But now we need to focus on the main point, so we're not confused. Here, diuretics, you have if you want to take it, you want to prescribe or patient can take with hyperlipidemia and gout with caution. Okay, the same thing for dyslipidemia. Also, they increase the triglyceride. Also, and why this triglyceride can be increased. Sometimes can be explained, sometimes we cannot explain. Still, there is no study or very not clear very well. Okay. Beta blocker in the hypertension patient with diabetes mellitus. I said previously, right? This is if you want some advantages to use beta blocker in this patient, or maybe due to other factor, cost, or maybe little bit of income. So you have to think about many things when prescribing this medication. If you want to use beta blocker in the patient, in the hypertensive patient with diabetes, you have to take with caution. You think why? You will worsening the condition like the previous one. What do you think? No. You will not worsening you will not increase the blood sugar. No. But you will mask the hypoglycemia. Okay? Because one of the main problems for diabetes mellitus is they get hypoglycemia and he cannot, because they will go in coma, right? This is the most important. So that beta blockers here, they will not worsening the condition for diabetes, no. But they will mask the hypoglycemic effect of any other condition. That's the right word. So that normally in hypoglycemia, what we feel? Sweaty, right? Sweetening and weak, shaking also. But beta blockers, normally they mask all these symptoms. Even though, I'll give you another point. Normally, if you have an interview or the surgeon will go to inside the operation rooms and his hand is still shaking very little, he can use 10 milligram per annum of beta glucose to stabilize the hand during the session, or to be confident when you go to the interview or not shaking or sweating, right? Isn't it? When you go interview for job or for a scholarship or whatever, right? So now we can use 10 milligram. 10 milligram, very small dose, not the antihypertensive. So that I'm giving you this one to link with beta blocker, not you, maybe we use in the patient with hypertensive patient with diabetic with cure or caution. Why? Why? Because can mask or heighten the symptoms of hypoglycemia. Right? Okay. Second point, peripheral beta blocker hypertensive patient with diabetes mellitus. Also, we also all the adults with no comorbidity and very elderly with no comorbidity condition. I don't have any idea why alpha blocker also can also use inclusion, but from my knowledge, I'm not sure about this point, but just keep in your mind. Normally, alpha blocker, the main problem for this class, pulmonary hypertension. Pulmonary hypertension that can affect, because when, especially in elderly patients, they'll be very clear. When you sit down, when you want to come, get up, you will be drowsy, you cannot stand because his blood pressure cannot stabilize very fast. Okay? I think this is the main reason. Otherwise, you can figure out if you get another reason, please. Yeah, you can share. Okay. Administration of antihypertension medication. Okay, what I need to explain here. For first line medication for primary hypertension are thiazide diuretic, as I mentioned before. Do not prescribe AC inhibitors and angiotensin receptor blockers together or in combination with direct renin inhibitors. Is not recommended. Okay, why? Why we not recommend or we try to avoid to using this combination for renin angiotensin system drugs that can lead to increase or lead to risk of hyperkalemia. Okay, so now what's the problem for hyperkalemia? If the calcium increase the blood, yes, toxicity for heart. So that is very clear, right? So they not prefer to use this combination or try to avoid. Patient with chronic kidney disease that potassium is more than 5.5 milliequivalent per liter, and those who taking potassium supplement or potassium sparing drugs are